That is a platform postdoc researcher who attended medical school at Northwestern University, Feinberg School of Medicine. He completed his residency in internal medicine and fellowship in pulmonary and critical care medicine at Columbia University, a medical center in the United States. Currently, he's pursuing a Master of Science in Biostatistics at Columbia University, focusing his research on medical ventilation parameters during extracorporeal life support in acute respiratory failure. He'll be presenting to us today the topic on outcomes in AHRF trials, challenges, and opportunities. Thank you very much, Richard.
Thank you so much, Kathy, for the introduction and for the invitation to talk today. I'm just going to share my screen in. Just confirming you can see the correct screen.
Yes, thank you.
Very good. So as Kathy said, we're going to talk a little bit about outcomes in respiratory failure trials with a particular eye to design in the platform trial setting. Just to start, I have no conflicts of interest, and listed here are just a couple of our funding sources. We'll start by talking about just the objectives for this lecture today, where first we'll talk about why outcomes matter, sort of just in general, but then also in the setting of respiratory failure trials. We'll talk a little bit about the regulatory recommendations and other core outcome measurements that currently inform what decisions we make. But then we'll talk a little bit about some of the limitations with the outcomes that we most frequently use, and also look at some other novel strategies and novel types of outcomes that might in the future provide some just very interesting opportunities for use. We'll talk about the value of incorporating patient perspectives, and then finally conclude by talking just really about how this all fits into the larger platform trial setting. But before we begin, we should really just define some terms. First, what is an outcome? So a couple of definitions here. An outcome is really sort of the key thing or sort of device that you're using to monitor the effect of an intervention or exposure on the health of a given population, or in fewer words, an outcome is a specific measurement or observation used to assess the effect of an intervention on a health condition or characteristic. And why do outcomes matter? First of all, I think important to note that the primary outcome of a study is really intimately connected to the success of the trial intervention. Whether a study's final designation is negative, neutral, or positive depends on what happens with the primary outcome. And of course, statistical power calculations and sample sizes are all wrapped around what we choose as our primary outcome. And that in turn then informs the costs of research and also the amenability of funding agencies to support a trial or not. And so when we think about outcomes specifically in the setting of randomized control trials, we think about the primary outcome, which is the main effect being measured, but also secondary outcomes, which add additional nuance or layers of complexity to the primary outcome. And then finally, exploratory outcomes, which are really viewed more as hypothesis generating and might not actually even be included in statistical analysis. Finally, before we move on, we'll just very briefly talk about different types of outcomes, since we'll be referencing these throughout the lecture today. We think about continuous outcomes, which are sort of numbers on a linear scale. Some examples in the setting of respiratory failure could be something like P to F ratios, severity scores like a SOFA score, or even lab values like IL-6 or other interleukins. And then in contrast to continuous outcomes, we also think about categorical outcomes, which can come in different forms. You can have a binary outcome, which is a yes, no outcome. Something like mortality, is a patient dead or alive, would be an example of a binary outcome. But then also we can have categorical ordinal outcomes, where we have a number of different categories, really in a hierarchical scale, which an example of respiratory failure could be something like the level of oxygen support that a patient requires. So with this little bit of background, then let's begin first by talking about what guidelines exist and what recommendations do we have that currently inform selection of outcomes in clinical trials. And one of the most robust sets of guidelines comes from the European Medicines Agency. 2006 is when they published their last set of guidelines, and they're in the process of releasing and reviewing an updated set. But I think some highlights from this set of guidelines. First, really the primacy of mortality, where they say that all-cause mortality at day 28 since randomization is the most relevant primary endpoint in trials of ARDS. They also go so far as to say that days alive and off the ventilator at 28 days, which is another very frequently and commonly used outcome, is not recommended as a primary endpoint. And they gave two specific reasons for that. The first is just because of differences in sort of local or regional differences in extubation strategies, and also just the risk of bias in open label studies. The second is that if a patient is extubated and then reintubated, those days off the ventilator in between two periods of mechanical ventilation aren't really regarded as having real clinical benefit. So for these two reasons, they recommended against the use of days alive and off the ventilator at 28 days. Some other specific recommendations, they said for secondary endpoints in this setting, days alive and off the ventilator is more appropriate. Days in the ICU, days requiring vasoactive medications, and then complications should be considered. Other short-term endpoints looking really more at physiology, lung parameters, P to F ratios, and then other involved organs could also be considered. Just to quickly highlight some things from the sort of newest recommendations from the EMA. These are not finalized and under revision. Again, they reaffirm the relevance of mortality at 28 days, but at the same time recognize some of the challenges with accrual, that it may be hard to recruit a sample size large enough to actually show a meaningful reduction in mortality. They do offer some alternative suggestions, such as composite endpoints, and we'll explore some of the challenges that they're touching on here with accrual, with composite endpoints, a little later in the talk. But now let's move on. We've seen what outcomes regulators believe to be important, but what about recommendations actually from our community, from the respiratory failure research community? So we'll look at three sets of core outcomes, each for a different population with respiratory failure. And we'll start with this set of outcomes published by Danny McGauley and colleagues in 2019, looking at core outcomes for critical care ventilation trials. And so this was a paper they published after a really involved Delphi study. Involved a couple stages, a number of rounds of sort of running through different options with participants, over 200 experts involved in the Delphi study. And in the end, they concluded with 6 different outcomes that they felt were important and should be included in ventilation trials. These were extubation, or the time from randomization to first extubation, but then also reintubation, meaning did the patient fail and did they need to be put back on a mechanical ventilator? Time to event information, like the duration of mechanical ventilation, but also length of stay metrics, time in the hospital, time in the ICU. They do include mortality, but also include health-related quality of life. Next, a similar study, but in a more focused population. This was published by the ECMO-Net research group, looking at core outcomes specifically in the ECMO population, again, using a modified Delphi study to arrive at, in this case, 8 different outcomes in 3 domains. So there's an adverse event domain recognizing just the high bleeding risk in patients who are receiving ECMO. Mortality, again, figures in here, as well as a number of quality of life and life impact metrics. Finally, a third paper here, again, looking at core outcome measures, this more in long-term follow-up and in survivors of patients with acute respiratory failure. So similar structure, a Delphi study that identified 4 outcomes in a number of different domains. Again, satisfaction, quality of life with the EQ-5D, a couple of different mental health scales, and then also pain, as many patients who are survivors of critical illness might have long-term sequelae beyond just respiratory function. Worth noting that there were a couple other outcomes that did not achieve the consensus metrics of the Delphi study that were also deemed to be important by many investigators and experts in this panel, which included cognitive function as assessed by the MoCA blind survey, some measures of physical function like a 6-minute walk test. And while many people thought that pulmonary function strength testing was important, there was really no ideal or agreed upon way that any of these should be measured. So they were just really mentioned as things that are important, but the investigators here didn't give an actual recommendation about how these outcomes should be assessed. They also note here that there's a number of different ways that you can combine different measurement or assessment tools to arrive at sort of achieving these outcome measures, and listed here are just a couple of these different combinations. So just to summarize a couple of the key points here, I think both regulators and experts in the field agree on a couple points. First, that mortality really matters. Saving lives matters, of course, but also that quality of life matters. I think we've seen that both in the EMA recommendations, and each of these 3 core outcome sets all include some metric of quality of life, whether in the short term or longer term, months or even a year after index hospitalization. Now that we've spoken a bit about some of the evidence and recommendations that inform how trials have been designed, I will turn now to talk a little bit about what are some of the specific challenges we face when we select outcomes for respiratory failure trials. And some of these challenges are really just inherent to the nature of the disease itself. I think, as we're all very familiar with, respiratory failure and ARDS is an incredibly heterogeneous condition. And so it can be really hard for a single outcome to encapture the inherent variability in the condition. As you see here, some trials have found sort of differences in outcomes depending on P to F ratios, as you see up top here with high and low sort of differences, but also a lot of work in the last decade or so looking at biological subphenotypes, hypo or hyperinflammatory, where different strategies might have very different effects in these populations. Another challenge, which is really just itself a feature of doing investigative work in the critical care setting, is that in the ICU, we're very often dealing with competing risks. And so what do we mean by that? I think helpful to look at this paper, which shows just a nice conceptual framework for competing events, just looking at a couple of examples. In panel A, you see that you can have mutually exclusive absorbing states. And so what we mean by that is, if you specify an outcome to be something like respiratory failure related mortality, then that's an outcome that would be competing with other types of mortality, whether that's mortality due to cardiac events or other types of organ failure. I think, as opposed to something like all-cause mortality, which would subsume all of these different categories into one final absorbing state. Panel B is also interesting, and we'll spend a little more time exploring this type of competing event in just a moment. But this is where you might have an outcome of interest, something like successful extubation, but that might be competing with mortality events. And so statistical approaches need to be very refined and nuanced to deal with these competing events, and your outcome has to take all of these things into consideration to efficiently show what the intervention is doing or not. And so let's look at the example of ventilator-free days, which is a particular outcome where you can see this challenge of competing risks come into play. So this is data that comes from a reanalysis of a couple studies, and we'll focus on just one of them, the HARP-2 study, which was a trial in ARDS that compared simvastatin to placebo. And when the investigators looked back on their data, they noted a couple of things, which is just the distribution of the data, where when you look at the number of patients who sort of had what range of the primary outcome, which is ventilator-free days, there's really a bimodal distribution where you see 2 peaks. The first peak is here where patients were assigned a value of 0, meaning that they either, at the conclusion of 28 days, were either still on the mechanical ventilator or they had died. And then there's a second peak sort of farther along in that range of 20 to 27 days or so. And why this matters for the trial is the mean ventilator-free days for all patients was 12. But you see that this mean value doesn't really represent the data distribution because it falls in a zone between the two peaks. And so in the initial publication, they'd done analysis with a t-test, which, because of sort of these features, didn't show a statistically significant difference at all between the simvastatin and the placebo group. The p-value, I think, was 0.2. And so in this reanalysis, they asked the question and said, well, what if we think about other models that can better approximate this bimodal distribution? And so here you see on the left side of the panel, the normal distribution. That's what they use in the initial analysis with a t-test. The normal distribution doesn't in any way approximate what they actually observed in the study. A Poisson distribution also really wasn't effective. But then when they looked at modified versions of Poisson distributions, like this zero inflated Poisson model, which accounts for excess zeros, or on the right side, this logit Poisson hurdle model, which doesn't differentiate between true zeros and excess zeros. Then the results were really interesting because in this hurdle model in particular, they found that the simvastatin arm had a significantly higher number of non-zero values. So everything other than that tall column on the left side compared to the placebo. And so that indicated that more patients were alive and free of mechanical ventilation in the simvastatin group. When they applied this same type of modeling to some of the other studies, interestingly, they observed something very different in the ALTA study, where there was actually, and this had been sort of published as a negative or neutral trial, there was actually a signal for harm in the intervention group. And so the point of this is that competing risks can be very challenging to deal with, both sort of in conceptual models, but also just in your statistical analysis. And so we, I think, really need to look for better statistical models to handle some of these features. And now let's move on and think a little bit about some of the challenges that we face at specific phases of the clinical trial process. First, with the early phase, like phase 1 or phase 2 trials, very often, I think we're challenged with small sample sizes. We're not really looking with the larger sample sizes that we see in phase 3 or definitive trials. And so very often we're stuck using surrogate outcomes or surrogate endpoints instead of some of the traditional outcomes like mortality, which are favored in definitive trials. And this was a really interesting study looking at just the range distribution and types of surrogate endpoints, just using critical care in general. And going through, I think, a couple key categories come up. First, there's a number that look at time and duration, some of which might be appropriate in larger phase 3 trials. Things like ICU-free days, organ failure-free days. But then also you see things like illness severity scores, SOFA, lung injury score, gas exchange metrics like the P to F ratio, oxygenation index, and a host of biomarkers and lab surrogates. And I think there's a couple challenges here. One is that when you're using surrogate outcomes, in particular some of these biomarkers, you might see a very real effect in the phase 2 trial setting. But unfortunately, because you see a trial effect or see an effect in this early phase trial, doesn't necessarily mean that you'll still see something in a definitive phase 3 trial, which might use a different outcome. And so I think sometimes you see that pipeline of phase 1 to 2 to 3 be interrupted at the 2 to 3 stage as you transition away from surrogate markers. But then the other challenge here is that very often surrogate outcomes and the outcomes that we use in phase 2 trials really aren't patient-centered. And that's something that we'll focus on a little bit later in the talk about why that's really so important when we're selecting our outcomes in trials of respiratory failure. But then what about larger trials, definitive trials? And I think we're starting with the question, is mortality actually a useful primary endpoint in respiratory failure? I think it's also worth reflecting a little bit on, like, why is there actually so much emphasis placed on mortality? And a couple reasons again. I think, first of all, mortality is very easily and unambiguously measured with low risk of measurement bias. I think there's just a lot of history here where and the majority of respiratory failure trials and other critical care trials have used mortality. Although I think it's important to note that many of these trials had negative results. But then I think something that really matters a lot to regulators when they're looking at industry trials, drug trials, is that mortality has very long been regarded as a crucial patient-centered outcome. But that being said, I think there's some very interesting challenges we face here, some of which are even just how mortality has changed over time. And this was a study published 15 years ago where already then investigators were beginning to realize some of the challenges with using mortality as a primary endpoint in respiratory failure trials. So this was looking at the observed mortality in a number of sort of key or groundbreaking respiratory failure trials from 2000 to 2010. They divided the AHRF trial into the control and the intervention arms, but then otherwise aggregated all the patients from the alveoli, FACT, ALTO, OMEGA trials, and found that there was a statistically significant decrease in mortality over time as standard of care improves. And while, of course, I think that's really exceptional for patients and reflects just a lot of the advances in the field, this can pose challenges in the research setting. Just as a thought experiment, I think interesting to think about some of the numbers, where the AHRF trial, which was published in 2000, recruited 861 patients, and accepting some of the COVID-19 trials, which really operated under exceptional circumstances, remains the largest trial in ARDS. But if you were to design this trial today based on contemporary ARDS mortality rates, the trial would need to recruit really another 300 patients to detect that same 8% absolute reduction in mortality with a 90% power. And so this, of course, has implications for sample sizes, for costs, for the time that we need to accrue patients. The other thing is, and this comes from really fascinating work done by Michael Harhe and others, is that when we think about mortality when we're designing studies, and we sort of do our initial power sample size calculations, it turns out we're just sort of really bad at accurately predicting sort of the degrees of mortality or what mortality we actually expect to see in the study. This is a figure from a systematic review where they looked at just sort of differences between what investigators thought would happen and what actually happened in a number of critical care trials. And you'll see, looking at this figure here, the horizontal white bars are what investigators expected, and then the black lines are what actually happened. And so this is looking at the absolute mortality risk difference and the difference between what was expected and what observed. And so what they found is of 34 superiority RCTs comparing mortality between treatment arms, less than 40% actually accrued a sample size large enough to show a reduction in mortality. And of these, the observed control arm mortality rate, so that's what should be sort of closest to what we expect, differed from what we expected by at least 7.5%. And so the point here is that I think we need to be sort of very pragmatic when we're designing trials and choose mortality as a primary outcome, recognizing that we might need very high sample sizes to actually achieve a real difference between arms. So just summarizing a couple of the points here. First, respiratory failure is a very heterogeneous condition. Competing risks can pose interesting methodologic challenges. Thinking about the early phase trial setting, surrogate outcomes may unfortunately not really predict performance in definitive trials. And finally, mortality often requires very high sample sizes. Now we'll move on and transition to talk a little bit about novel outcomes and other opportunities. And we'll start by looking at a couple of just really interesting methodologic and statistical approaches that might offer some solutions to the challenges discussed earlier. So we'll start by talking about composite outcomes. And first, just to define what is a composite outcome, So this is a outcome measure that combines two other outcomes into sort of one statistical analysis. Very often it's something like, for example, days alive and free of organ support. And so that's the kind of outcome that includes both a mortality aspect, that's the days alive, but then also organ function by looking at days free of organ support. This was a really interesting systematic review published just last year that looked at the use and impact of composite outcomes in critical care trials. I think the first thing to note here, as you see in this graph, the number of studies incorporating composite outcomes has really increased over the last decade. This just looks at like what are the different components of composite outcomes where things on the more yellow-green side are more frequently used, and things on the dark blue or purple are less frequently used. So almost all the studies that use a composite outcome did have mortality as some component, and then sort of the next most frequently used part of a composite outcome was some form of organ support. But important to note here is that when you compare power between those studies that use composite versus just regular non-composite outcomes, there was no difference at all in power between these two categories. And then the other thing to note is similar to that analysis we saw of expected versus observed mortality. Again, here with composite outcomes, because you're incorporating sort of more complexity into the outcome, sometimes we're even worse at predicting what's actually going to happen when we're setting up sample sizes. And so in this paper, they saw that predicted effect sizes were overestimated in all but 6 trials. The other interesting thing that they noted here is that while using composite outcomes can allow you to use a smaller sample size, in none of the studies was there an increased likelihood of statistically significant results. And so talking about and thinking about other statistical approaches, the win ratio is another technique that we can use to analyze composite outcomes. And we'll just show an example here. This was a paper that looked at ultra-low tidal volume ventilation compared to just traditional lung protective ventilation for COVID-related ARDS. And their primary outcome used a win ratio, which itself was a combination of 2 of the specified secondary outcomes. So it was something that combined both 90-day all-cause mortality with ventilator-free days at day 60. And while these things were pulled apart in the secondary analysis, what the win ratio does is it looks at pairwise comparison of individuals in the intervention versus the control arm, and it looks to see who won based on sort of assigning different values to the outcomes. And so each pair is either a win, a tie, or a loss, and then the win ratio looks at sort of the aggregate of all those things together. Some issues with the win ratio. It's not a perfect statistical technique, but another option for looking at competing risks. I would just refer you to this paper if you're interested in just other statistical approaches for thinking about ventilator-free days and some of these other competing risk models. But now we'll turn away from statistical techniques and think more about just novel types of outcomes. And we'll ask first, what about longitudinal outcomes? And what do we mean by this? So these are outcomes that are measures repeated at fixed intervals over time. So rather than waiting until 28 days to assess mortality or 28 days to look at the number of days spent on a ventilator or not, this is something that's assessed often daily over the course of a set interval of time. And so because you're looking at not just one time point, but sort of the trajectory of a patient, you can get a lot more information about clinical course. And you can also consider the time-dependent effects of treatment, which might be very different even if the outcome is sort of final outcome is the same between groups. Because you gather so much rich information every day, there's the possibility to increase statistical power, but at the same time, need to consider that type 1 error may increase if you're increasing statistical power. I think the other sort of interesting thing, and we'll look at some examples of longitudinal outcomes in just a moment, is ordinal outcomes, like we talked about in the beginning, where you have different sort of hierarchical categories, also might have some promise in respiratory failure. The neurology field has been using this really for quite a while, both for individual patient outcomes, looking at sort of the extended Glasgow outcome scale, but even just in how they're analyzing sort of a lot of their data. And I think I've seen really very interesting reductions in sample size requirements when they move from continuous to ordinal outcomes. But now what happens if you combine ordinal and longitudinal outcomes? And we'll walk through two case studies that I think illustrate this sort of this very powerful combination. The first coming from the influenza literature. This was actually just a cohort study, really looking to see what happens when you select a ordinal longitudinal outcome as the primary outcome in the study. And the initial questions that these investigators were asking is, a number of studies, both observational as well as interventional, have shown that there's really not often a difference in mortality and length of stay in patients who have influenza A versus influenza B. But a lot of anecdotal evidence suggests that influenza A might actually be more severe than influenza B. And so what these investigators did is they built a ordinal severity scale and used this as their outcome. And basically what this scale was is it was severity of disease based both on level of stay, whether the patient was home in the ICU or in the non-ICU on the wards, and then also what degree of supplemental oxygen the patient was requiring, whether that was just low flow oxygen, invasive mechanical ventilation, or even ECMO support. And then how did they use this? They defined their primary outcome as the rate of clinical improvement, which meant that you had declined in 2 disease severity categories. Just to go back to that, for example, if you'd started on ECMO, you would have had a category 6 at the beginning. And so an improvement down to a category 4 would have met that criteria of significant clinical improvement. And then what they did is they looked at that outcome longitudinally over time. So for patients in the influenza A arm, every day they counted the number of patients who had whatever level of score that was, and then looked at that over the course of 28 days. On the right side, you see they did the same for influenza B. And just looking at things visually, you can see that there's a real difference between the two groups, where influenza A, you see there's a higher proportion of patients who have that sort of maroon, purple, gray-brown color, indicating higher severity of disease. And in fact, when they looked at their primary outcome with hazard ratio analysis, they did see that there was a statistically significant difference in improvement rates, where patients with influenza B did improve more quickly than those with influenza A. But now we ask, does this work in the setting of randomized control trials? And a couple of trials, again in the influenza space, but also more recently in COVID-19, have used very similar scales when designing the primary outcomes. So this was a study that looked at remdesivir for the treatment of COVID-19 respiratory failure. And they used a modified version of the WHO COVID-19 severity scale, very similar to that same scale we just looked at for the influenza study, where patients were given a severity score, again, based on level of acuity and the degree of oxygen support that they required. Interestingly, they didn't find any difference in mortality between treatment groups, but did find a significant difference in time to recovery. And there was this second outcome that was actually their primary outcome that was defined by these severity categories on the ordinal scale. As you can see here, again, there's a nice separation between the groups as time went on, between the remdesivir and the placebo group. The other, I think, sort of fascinating thing that a disease severity score like this allows is just a bit more of a nuanced look at what's happening within each of these categories. And so panels B, C, D, and E are all patients who required different degrees of oxygen support. And so having that data built into the design of the study allowed the investigators to really tease apart what was happening within each subgroup. And I think particularly fascinating is they saw that all the benefit was really coming from those patients in panel C, patients sort of in that intermediate range of severity who were requiring oxygen, but not so sick that they were requiring high flow, non-invasive ventilation or ECMO. And so just to summarize this portion of the talk, I think we've seen that there are some novel statistical techniques that might be better equipped to handle some of these challenges like competing risks and sort of composite outcomes. And then ordinal and longitudinal outcomes might offer increases in statistical power while also allowing us to remain patient-centered. And I think that leads us into the next part of our talk, which is, well, what do patients think about outcomes in respiratory failure trials? Because that, of course, needs to be a very central part of what we're doing. This was a very interesting study published early in the pandemic. There's an international survey to establish prioritized outcomes for clinical trials in patients with COVID-19. A number of investigators, clinicians, patients, families, and the public were all involved in this study. Many thousands of people surveyed. And what you see here first in this radar chart, this is showing the different values of importance that different groups were assigning to a number of different outcomes, where patients are noted in the red color, health professionals in the gray, and then the general public in that sort of blue teal color. And you'll see that while the 4 outcomes of highest priority were the same for all 3 groups, that was mortality, ongoing respiratory failure, the incidence of pneumonia, and organ failure, there were a number of other things where patients had very different priorities. As you can see here, whether there was ongoing chest pain, fatigue, muscle pain, some of these more quality of life things that I think patients are just all too intimately aware of. And so we ask, why aren't we so sort of really attuned to or good at incorporating some of these patient-centered outcomes into our trials? And I think a couple of reasons, as was pointed out by these authors. First is that I think, unfortunately, we don't often do a good enough a job of including patients in the design phases of our trial. Second, there's really not necessarily consensus on what are the specific domains and outcomes that actually are patient-centered that we should incorporate. And then a number of sort of what we consider to be patient-centered outcomes focus on quality of life. And there are many different tools that we can use to assess these. And because of the sort of high heterogeneity in these assessment instruments, sometimes that leads to a bit of fatigue in actually selecting what is the best outcome to actually use in my trial. And so now let's talk about sort of in this final couple minutes of the talk, well, what about outcomes and platform trials specifically? And some particular considerations. First is sample size, that platform trials by design may incorporate many centers around the world, might sort of even incorporate multi-platform structures into the design of trials, and so might thus be able to accrue many patients very rapidly. But then the other piece is that because of their complexity, different domains within a platform trial might have very similar or, in contrast, very different priorities. And so sort of maintaining some degree of coherence might be done in different ways between different types of platform trials. So just to highlight 2 examples, we'll start by talking about the REMAP-CAP platform trial looking at community-acquired pneumonia. And they've taken a very centralized approach to outcome specification, where their master protocol states that the primary endpoint for all domains will be all-cause mortality at 90 days. And so they've sort of very strictly applied this definition in all their studies. Really a number of different interventions all use this primary outcome. There's a number of other outcomes that they use, like in the ICU setting, they look at ICU mortality, ICU length of stay, ventilator-free and organ failure-free days at day 28, and then also the percentage of patients who receive a tracheostomy. Other hospital outcomes, they look at just general hospital length of stay, where patients are discharged to, and then the need for readmission. Again, these are outcomes that are shared across all the domains, all the studies on the ReapMap CAP platform. The practical platform, in contrast, has taken a bit of a different approach. And as you can see here, again, the point is not to try to look at all the lines of data here, but rather just really the vast heterogeneity of the outcomes utilized in the different domains, where the vertical columns to the right of this figure represent specific domains or studies within the platform. And then the horizontal rows are different outcomes. So you can see that while there are some outcomes that are conserved or shared between domains, there's many that are very different between them all. And the green boxes indicate the primary outcome. So again, primary outcome can be very different between domains. And the practical platform master protocol states that because this platform is intended to host trials focused on various aspects of respiratory failure, and also at different phases of investigation, we cannot specify a single primary endpoint for the entire platform. And so how this is operationalized is that the specific primary and secondary endpoints are just defined within each domain protocol. At the same time, there are still some shared endpoints between all the domains, sort of irrespective of the intervention or the phase of study. Some of these focus on survival, thinking about survival status at hospital discharge, ICU discharge, or disconnection from mechanical ventilation. There are length of stay metrics, and then also time metrics, looking at the duration of mechanical ventilation and the number of vent-free days to day 28. Practical also looks at some safety endpoints, looking at sort of changes from one state to a more severe state, as well as serious adverse events. And finally, I just want to highlight how platforms can also facilitate sort of collaboration across platforms and really across international consortiums. The Outcomes Working Group is a particular collaboration between the Panther and Practical platform trials. And its objective is to sort of think about some of the challenges that we've spoken about today and develop and validate a novel outcome really for the early phase 2 trial setting in trials of respiratory failure, with a particular interest in developing something that may, in the end, be ordinal or longitudinal or both. And so just some conclusions today. I think first, helpful to realize that core outcome sets are readily available, sort of well-validated, and can help guide our selection today of what outcomes are most important to include in trials of respiratory failure. There's a number of novel statistical techniques that can augment the utility of composite outcomes in particular. I think a lot of excitement about the use of longitudinal data analysis and ordinal scales and how that might play into the choice of primary or secondary outcomes. And not to forget that patient and public involvement is incredibly important when we're thinking about what's actually important, because of course, this is why we're doing the work that we do. And then finally, just because of their complexity, platform trials might adopt different approaches to selecting outcomes based on sort of the underpinning philosophical approach that sort of informs the structure of the platform trial. So before we conclude, just want to make a couple of acknowledgements. First, to the Practical and Panther Outcomes Working Group, much of whose some of the things we talked about today. Primary supervisor in this work, Ewan Gallagher, and several other members, sort of leadership in the leadership of the working group, Andrew Boyle, Eric Lavlam, Dana McCauley, and Bram Rosberg. I want to thank all of you for coming today, and happy to take any questions. Thank you so much.
Yeah, thank you, Richard, for a wonderful presentation. If you have any questions, can you maybe raise your hand or speak up? I'm not seeing a particular hand. Okay, maybe can I ask a question, Richard?
Yeah, of course.
Yeah, so I think you mentioned a little bit about the guideline from EMA, but do you know if they are going to update any outcome recommendations or like during your work on the outcome group of a practical panzer, are you keen to work with them somehow? Because I think if it's an early phase trial, particularly, then I think we may need to pay attention to their perspective on top of patient perspective. What's your thoughts on that?
Yeah, thank you so much for the question, Hiroki. And I think you're hitting on something incredibly important, which is as we design trials and if we're looking to design a novel outcome, I think we really need to consider sort of the perspectives of regulators. And so just to sort of first focus on the European Medicines Agency, EMA, work that's somewhat, I guess, separate from the outcomes working group, but a number of investigators were actually invited by the EMA to review this initial update that they've published and to comment. And so the working group is also sort of involved in some of this conversation. I think in particular, I think there's some concern about the EMA's emphasis on mortality as sort of the best primary outcome for respiratory failure trials. Just because, like we've said, it can be really just hard to achieve sufficient sample sizes to show a difference. So there's ongoing conversations there. The other piece I'd add is that we're actually in the process with a working group of inviting the FDA to join the working group, perhaps initially maybe only in a listening only mode. But I think I think we agree with you that's super important that regulators sort of agree with the priorities that we're identifying when we're thinking about what's important for an outcome.
Thank you. Yeah, I think just as a follow-up question, I think part of the reason why I asked this question is that recently I attended a conference among Japanese researchers or stakeholders, and then essentially the Japanese regulatory agency kind of still recommended double-blind RCT. And then related to your talk, do you also pay attention to how outcome measures is measured? Meaning like who is gonna being assessing the outcome, for example. Some outcomes can be biased to assessors. So do you also pay attention to that kind of aspect as well for outcome measurements?
Yeah, I think again another very important consideration. I think again, these are, I think, in some ways wrapped into the conversations with regulators where EMA and FDA have both, as you've sort of said, emphasized the importance of double-blinded assessment. But I think often we see that it's not always practical to blind investigators depending on the nature of the intervention. That being said, I think having the outcome assessed by sort of blinded assessors, that's super important. And I think we hope to build that into whatever kind of outcome is developed by that working group. Would hope that it's a sort of outcome that can be assessed in that fashion.
Thank you. Yeah, William, can you speak up?
Yeah, hey, Cameron McGuire here. I'm one of the junior faculty at UC San Diego. Wonderful talk, and thank you so much. This is more of sort of a practical advice-giving question for you, which is, even with an MPH in epidemiology and sort of heavily involved in clinical research, I feel like a lot of the statistical methodology and technique that you covered today is so incredibly complex that I have trouble keeping up with it and or thinking about how to apply it in an a priori fashion to my studies. And I'm wondering if you have some resources above and beyond the primary literature that you covered really nicely today as to maybe ways that I can bone up on some of this stuff as I continue to sort of design my experiments moving forward. Thanks.
Yeah, thanks so much for the question, and agree with you. I think some of this is so novel. I don't know if there's a good sort of centralized place or like a textbook or anything that incorporates some of this. So I think as a group, we've really relied a lot on the primary literature. And I think I've just looked to find sort of content experts in this area, and then we'll try to talk with them and direct my questions to them as we're thinking about some of these methodologic concerns. But certainly, I think as a working group, as we sort of move forward and sort of think about these questions of where do our sort of resources lie, if there's particular things that we find, I think we'll be very happy to share them with this larger group.
Great, thanks so much.
Yeah, there's one comment from Ian. I don't see the last name, sorry, but they said primacy to mortality does not recognize that there are some fates worse than death. Yeah, thank you for your comment. Any other questions? Kathy, do you see any comments, questions from anyone else, students?
No, I don't see anyone else who has concern or questions.
Okay, then I think we're gonna give you guys a couple minutes. Kathy, when it's gonna be the next webinar, if you have any announcement? Thank you.
Sorry, I thought I unmuted myself. Yes, we do have the next scheduled webinar on April 23rd. There will be flyer and email notification shortly. Thank you very much.
Okay. Thank you so much, Richard, for your wonderful talk. And then I hope that you will continue to join the next webinar as well. And then, yeah, thank you so much again for all. And then see you soon. Okay.
Thank you so much.
Thank you so much.
Yeah. Take care.
Bye.